Good morning, ladies and gentlemen, uh, colleagues, friends, chair, and my special thanks to Professor Jamal Belkadir and his team for inviting me here. As I told you yesterday, that this is my first time, and hopefully this will not be my last time. I am enjoying too much. So what I'm going to talk about is the global burden of diabetes, in global perspective, and the role of the IDF, which is my friend Jamal has given me this topic. It's rather a political topic rather than a scientific topic, and which I'm very pleased to present as my responsibility as Vice President of the IDF. So this is one of the things that I need to do. So the way that I'm going to present is probably I will start with the estimated global burden, which is my topic. And then I will also talk about a little bit estimated mortality related to diabetes, which is not less addressed. And then I will also discuss why the estimates of projection is not reliable. Because we always we had some discussions yesterday that how do we make the estimations. And so we'll say that how the estimation, particularly for projection, is not reliable, and the role of the IDF in the global fight against against diabetes. So this is the way that I'll be presenting. Much of the slides are already known to you because we have already talked a lot of global burden of diabetes, but probably I will show it from a different perspective. You know that in 1998, first time that Harry King and his group, they estimated that there will be about 150 million people with diabetes. So this was the projection in 1998. Soon it changed to, for example, then they came up with the new data saying that 2000 to 2025, actually it will be 300 million people. And it is an increase from 151 to 300 million people, and from 15 million people in the US to 22 million people. And this was published in 1998. So it's a 1995 and 1990 change. And then came the so-called the global epidemic of fatness, obesity. And this has changed the picture completely. And then it comes then they were saying that there will be an explosion of diabetes because of this change. And then we came the new estimate in 2004. Then we are talking about 171 million people at that time. So you see the estimates are continuously changing. And then came the new one that 300, I think instead of 300, and then we came to 366 million people. And then actually this was corrected again to 530 million people. So you see that there is a continuous shift. There is a continuous shift of the global burden. And this is what I'm going to discuss, that why we see this kind of shifts. But before we come to this question, I will give you particular presentations on the top 10 countries which has already been discussed yesterday. But if you see these top 10 countries come because of the sheer number of people. For example, China, even they have a lower percentage, lower prevalence, but due to the sheer number of the people, there will be more people with diabetes. And I don't think anybody should compete to be the focus point, or the people with the highest number of diabetes is nothing to be proud of. But if we go by prevalences, then we see that, for example, in the Middle East region, then you see that there are a number of countries, the Kuwait, the Lebanon, Qatar, Saudi Arabia, Bahrain. So all these countries are coming up because they have a higher prevalence, but they don't have the biggest number of population. So that is the only reason they are not climbing up to the top position. So, but then there is also concern, as we have discussed yesterday, that's the undiagnosed cases of diabetes. And undiagnosed cases of diabetes is a matter of interpretation, because we make some assumptions. Because if we knew, then they are not undiagnosed, then we know them. So we presume how many people are not diagnosed. So this presumption is based on a number of factors, and that probably could give us a rise of this confusion that somebody will say that not 50%, as we have discussed yesterday, and Professor Mursi Arab rightly pointed out that it was 50% 10 years before. Today we'll be presuming about 30% because because the healthcare system is more effective than they were. It is true that when I was a medical student, we haven't learned a lot about diabetes. So it has, even the doctors, the GPs, they didn't know a lot about diabetes. It has changed. We still are struggling to put the diabetes in the medical curriculum. I hope that Morocco is doing better than many other places. So this presumption, because of that, I believe that number of undiagnosed cases has gone down. Yes, I will agree with that. And then you look at this, particularly in the MENA here, you see that this number is continuously changing, although, but these numbers are based on, as you have many people have already mentioned yesterday, based on one single study. And given that single study's prevalence, then we estimated the number of people in that country, in that age group, and then we calculated what would be the number of people. And that particular study may not be representative for the country because it's not a national representative data. Unfortunately, we do not, very few countries have a kind of national representative data. And this is the problem, this is the struggle that IDF does when we make this kind of estimations. Because it's like, you can think of a kind of, that the blind man who is looking for an elephant and describing the elephant. The blind man does not see the whole of elephant. The blind man holds the tail, and then he says that the elephant is a tall like a bamboo. It's a question that which part we are saying. So therefore, those who are criticizing it, because they have another data, but that data is not actually representative either. So we have a problem here. And this is not only a problem for the developing nations. If we think that many developed countries do not have a national data, the data that we have is hospital-based data. Population-based national representative data is very rare. You already know about these things, so I will not depend. It talks about finance. It talks about increased demands on development and how many people are dying every single second. Diabetes is not only an issue of, it's a developmental issue, because in the developing countries, most of the people in the working age group, they are being affected. In the Western countries, people generally get it at the older age. We have done a study where it was shown that a man of 60 in Caucasian, not only migrants, the Caucasian in Europe, his risk for diabetes equals to an Indian of 20 years of age, 22 years of age. So you see that this kind of, so it's affecting the younger population. So diabetes has become a developmental issue for the developing countries. And then we are saying that leading causes of global death, and actually diabetes is coming up now. We still are struggling to get the proper data because the death data is very difficult, because people don't die of diabetes. People die of complications from diabetes. So therefore, if you look at the death certificate, it is never written diabetes as the cause of death. So therefore, we are struggling to get the proper data, but still now coming up, but we are thinking that it will be about 3.3 million deaths in 2030 related to diabetes. And then we are talking about it's about 5%, 5.2%. Given this figure, it will be about 5.2% of the total mortality. And this is equivalent to HIV/AIDS of 3 million. At the end of the slides, I will show you that how, when we are talking about the global funding, because funding is important, that how this data relates to the global funding. I will come back to that. And this has been hazard. We have shown, I'm just projecting one slide on this, because it is showing that, for example, we all know that with the diabetes, the risk for death is increased. So this figure actually tells us that there was a map. It was, again, it's a more or less, you can say, it's a hypothetical map. And then we tried to project, we tried to make the best estimates. What is the excess mortality in each country? And if you look at this, everywhere we see that the excess mortality is coming up. So everywhere we have this, there is again, with this estimation, it's pretty close to the previous one. We come to 3.1 million deaths, about 5.4% of all deaths. But you see that in all regions of the world, So there is an excess death related to diabetes. So that is one of our struggle. People are saying that, okay, people will die of any cause. People will have to die one day. But do they have to die prematurely? That's the question. These deaths we are seeing before the age of 65. And therefore, we are calling them premature deaths. And then I'm coming to some questions related to the things that why the former projections are inaccurate. Or not inaccurate, but it keeps on changing. And people ask me, one of the things, as I said, that we base on some information and which is not nationally representative, that is one thing. And there are a number of studies done on how to make the proper projections, and there are scientific guidelines that how do you make these projections. So let's say this is our paradigm. We don't have any pointer, actually. So let's say there's a boundary of judgment, and you have the observations, and you have the evaluation values. The observations are made from the information that we have from this sporadic data collection that we have from each country. If we look back, then, and this gives a dimension between our observations and for the evaluation. But the boundary is much bigger than this because it is not a kind of national representative data. So the boundary is much bigger than actually the information that we have. And then you can see that if you look at on the top, on your right-hand side, you see that there's a burden of diabetes. And then you see that there are three dimensions: the cost, the unhealthy diet, and the total prevalence that we count on. And the people diagnosed with diabetes. You see that when we say people diagnosed with diabetes, you know how many times we have changed the diagnostic criteria since 1999? We have changed 3 times. The diagnostic criteria of diabetes have changed 3 times. Now we are moving towards A1C, right? And that is going to affect our estimates again. Because all these diagnostic criteria that we do, it will have an effect. And then it comes the death. Then there is an inflow of the new cases, and there is an outflow, that is those who are dying out. And then people with undiagnosed diabetes, as you said, that this undiagnosed diabetes keeps on changing. As you said that Professor Mursi was saying yesterday, it's 30%, and we actually don't know. We say 50%, and it should be somewhere in between. And then it comes the people with undiagnosed prediabetes. The prediabetes who are also undiagnosed, and then the normal people. You see the whole interaction of all these people. And then this diabetes management, if the diabetes management is better, then it will reduce the number of people with diabetes. If we have an effective intervention program, it will halt the progression to diabetes. And then as diabetes diagnosis, as I have said, that it is changing, and pre-diabetes detection and management, and how effective we are in the community. For example, if we become more effective in future, then the number of people who will be pre-diabetes will be less. And the obesity in the general population, and what is the rate of obesity in the general population? Now we see that there is an increase, but we also see that there is a kind of people are more aware, the communities are aware, doctors are aware, and that may have an impact on the level of obesity, which is going to affect our estimates again, and gives us the larger view that takes us beyond the standard epidemiological models and most intervention programs. So you see that uncertainties, because we do not know beyond our observations. And this gives us, gives you the estimation of, for example, if you say overweight and obesity prevalence, which is, we see that peak, and we are expecting that it will come down with time. And we are also seeing the diversity of unhealthy habits and its energy growth. And then we also are seeking at the health protection efforts that each country under IDF, WHO, we are taking part, and the resources and resistance, that how much we can mobilize our resources, and the border, of benefits and supports. And this will affect the engineering growth of the epidemic. And it will also their responses to the growth, that if we are effective in response to the growth, we will stop the engineering of the growth. If we are less effective, it will probably be worse than we are estimating. And resources, resistance, benefits, and support. So it says that all these factors are behind the estimates that keeps us moving all the time. So if we say why the estimates are not correct, we cannot have a kind of direct answer, because there are many factors which are affecting our estimates. Okay, now question is that what IDF is doing. Okay, we have already seen. So IDF is an international diabetes federation, is a global advocate for more than 465 million people with diabetes. We say we are representing all the people with diabetes through our member associations. And IDF has 7 regional offices, and the principal aim of the regions are to bring local needs and activates to the attention of the local diabetes community, to translate global activities and objectives to a regional context, so that every chair of the region is a member of the IDF board of the 7 regions. So they are collecting the information from every member associations, and they are bringing it to the IDF to have the global perspective given taken from each of the regions. And we have about, at the moment, 230 members from more than 170 countries. And this is the largest diabetes organization in the whole world. That no country, no organization represents 130 countries. And IDF also enjoys the official recognition with the WHO, as well as with the UN and Economic Social Committees. So many people are asking that what IDF actually does. Actually, IDF has an important role. And to be honest, I probably would be more willing to talk what IDF is not doing instead of what IDF is doing. But my job today is to say what IDF is doing. So IDF is doing a lot, but nevertheless, I'm open for criticism that there are a number of things IDF could have done better. So these are the 7 IDF regions. As you see that there is one, the MENA region, where Morocco is. MENA is one of the 7 regions, and we have at the moment Nizar is not here. He's the regional chair, and Professor Basit has left. He is the chair elect, and we also have another regional chair elect from Africa. So he's also presenting here. So we have 7 regions. So these regions are very important. But what we haven't done, we said that we haven't consolidated. We could have done much more for these regions. At the moment, we are too much centered, honestly, we are too much centered probably in our head office. We are less centered, we should be more focused on the regions because we are dependent on the regions. And if you see the mission of the IDF is to be the leading authoritative global voice for the people with diabetes and those at risk for diabetes, and improve the quality of life of all people of diabetes, and prevent type 2 diabetes and fight discrimination against and affected by all diabetes. So this is one of the things, and this is one of the things that I should remind you that we haven't discussed very much about the discrimination. And this is also one of the job of IDF, its regional offices and the member associations, to be the advocate for the people with diabetes against discrimination. And we also, to promote diabetes care, prevention, and cure worldwide, the way that we do, we have these three pillars. The IDF has 3 pillars. It's partnership, policy, and presence. And in the IDF Global Voice of Diabetes, because we want to be the global voice of diabetes. If you look at this, for example, I don't want to mention any names about any organization. There are many organizations in the world, big organizations, with good scientific results, which they're doing excellent job from the scientific point of view, but they're not representing the people with diabetes. IDF is the only organization that represents all the people with diabetes through its member associations. So what is IDF is engaged at the moment? It is education. And in education that you have heard about IDF School of Diabetes, education models, guidelines, resources to support people with diabetes, and prevention. Prevention is the core core area for focusing from IDF, and its resources is primordial prevention. Research, as many of you know, that there are probably some people have also received fund from the Bridges program, and models for care for improved outcomes, primary prevention, access to medicine. This is one of the things that we are continuously fighting. That, for example, if you think of any kind of emergencies, in emergencies, there is what people go for. They go for diarrhea, they go for other kinds of infectious diseases, but they seldom think that in a kind of emergency situation, let's say the refugee situation that Nizar has picked up in the board many times about the refugee situation, and then how we can secure the emergency medicine. And so now we are trying to work with the Doctors Without Borders and to develop a kind of package with them and WHO for this. Atlas and Global Burden of Diabetes, as you probably most of you will consult, and research, cost effectiveness, diabetes prevention and treatment. The important IDF, among the important IDF projects, what this does, Life for a Child, it's a global diabetes atlas that we do, Young Leaders program that we have, diabetes retinopathy program, which is now a big one, and together with which foundation? Yeah, Hello's Foundation from Australia, and Bridges. This is a translation research support that we are providing, and now there is a phase 2. There will be a new program, and then we finally also make the World Diabetes Congress, which is one of the most important things. And one of the things that you can think that IDF is, when we say the member associations, there is most of the member associations until now they pay about $150 per year. The poor, small organizations. But for us to pay one person to come and to attend this World Congress, which we think is very important for the General Assembly and also for the World Diabetes community, it costs us some 2,000 to 3,000 euro per person for the ticket, for the travel, and the hotel. So IDF is trying to support. Altogether, I think our total membership fee is around about 200,000 euro, around. And our expense for this, one of these, to invite all our member associations for this, our expense is more than 1 million euro, about 1.2 million euro. So it's not that we are not trying to support our member associations. IDF is also are engaged in collaboration with the WHO. So we have taken this action plan, and is supported with from the World Diabetes Foundation and Diabetes Action Now. And then if you see this, for example, as I said, that we have WHO and IDF, we work together. What is the complementary strengths of WHO and IDF? And this is important for us to know, that WHO works with the governments. And it has a strong public health voice. And WHO offices in almost in every country, and is global reference center for health statistics, and has prestige among government health ministers. So these, we see the strengths of the WHO. And IDF works through member associations. We don't work through the government, we work through the member associations. And it has a strong lay professional advocacy voice. We have, because we said that we always have the lay membership and there is always there are some place in the board for the lay persons. And it's a network of member associations. As it's a federation, it's a network of member associations. And it's a well-developed secretarial, respond to all calls for information, and has prestige among the NGOs. We also have, so when we complement with each other, knowing our strengths, I think we have the potential to do it better than what we are doing at the moment. We have also taken the UN resolution of 16/225. We all is wearing this blue circle. We have this World Diabetes Day. This was the first time when we got this UN resolution. Diabetes was the first non-chronic, non-communicable disease which got the UN resolution. And this was done actually by a small country. This proposal was made by a small country, Bangladesh, in the UN, because the big countries refused to pay. There was only one country, and the person that he says, and this is important, the person that who made this proposal, he said that when people work with integrity and commitment for a noble cause, sometimes the world will listen. This tiny little country made this voice, and it was hard. And the IDF global strategies plan for funding, raise role of IDF regions, increase IDF technical base and political role. You see that IDF Atlas is the 4th edition, and it has number of things. It's definitive data, aligned WHO IDF. You can say that there are these data we often criticize that this is not representing my findings, but this is the best that we can come up to. At least this is being used as a reference for most of the publications. And still, we are probably not accurate, and we probably are not going to be accurate because of the factors that we have shown you before. And there is IDF centers for diabetes education, and I know that there are a number of member associations, and they have raised concerns because they are already promoting this diabetes education. Why IDF should be doing? IDF probably they can develop. I think it's no harm that they develop their strategic plan or a global plan for diabetes education, but it needs to be cooperated. It needs to be incorporated with the regions and the member associations. That I will agree. But at the moment we are doing it, and I think this is the good for training of the professionals, and all which will ultimately come to the best for the patient with diabetes. And then we also have Global Diabetes Foundation, which is for primary prevention. And IDF will also join forces with obesity and heart disease in NGOs, as I said, that NCDA alliance that we talked about. And yes, IDF is one of the founding members of the NCDA. We have also secured a Gulf Cooperation States proclamation on diabetes. It is signed by Bahrain, Saudi Arabia, Kuwait, Oman, Qatar, UAE, and Yemen. And this is the signed document. So there is something that we can say that IDF does. Now coming to the funding of non-communicable diseases and chronic diseases, which I think that the IDF is still struggling, and still we are not successful, unfortunately. You say that if you look at this, for example, total WHO expenditure in, if you say this total global NCD disease burden, if you look at communicable disease on the side, and rest of the things, if you say cardiovascular, diabetes, NCDs, and injuries also. So if you take it, you can say that it's more than 3/4 of the cake. And if you say the total WHO expenditure in NCDs, you see that 2% on the tiny little red mark on your right hand side. And this is the reality. If you see this, for example, this is our NCDs. Yes, NCD, non-communicable side, and on the right hand side it is our expenditure. And this is something that we need to change. And this is something that we need to be the diabetes community need to be very focused. That if it changes, it should go equally to all NCD causes, not only to one specific causes. And in 2002, 3.5% of the total budget of the US, this 43.6 million on the NCDs were spent. And if you say that it's allocated to NCDs including mental health, if you say it, and in 2004, it was 0.1% of the total expenditure. So this is something that that is our difficulties. We are still struggling. We have not been successful. And I think now it's coming NCDA. NCDA is welcome. IDF is a founding member of the NCDA. But we must secure that people with diabetes is not forgotten in that NCDA. And then in summary, what you can say, based on the demographic changes alone, the number of persons with diabetes in the world will be more than double in the next 30 years. That's for sure, no matter how much we agree or disagree with the estimates. In developed countries, they will increase by 30%, but 70%, in developed countries, they will increase by 30%, but 70%, mostly older person. But in developing countries, it will increase by 250%. And the next rise, the most rise actually will happen in Africa, and which is paradoxically that we are saying that this is the country that is, and mostly it will be between 45 to 60. But that's what I said, that this is the kind of, this is a developmental challenge. It's not a kind of, it's not a disease challenge only. It's a developing challenge. If people with 45 to 64 years of age are being affected, this will hinder the economical growth of each country. The projections do not take into account any increase that is attributable to future increase in obesity, that everybody believes that at least for the coming years that it will increase. So in summary, what we can say that about 3.2 million excess deaths are attributable to diabetes in the year 2000. In the US, this was 9% of all deaths, and it's about 5%, about 4.3% of the global death. The number of deaths attributable to diabetes in future years will increase, especially in the developing countries. And in final conclusion, I say increase in type 2 diabetes and obesity represents major public health challenge for the 21st century. We must stop it, because no matter whether you call it NCD or whatever it is, that entrance to NCD is diabetes and obesity. If we fail to focus on obesity and diabetes, we cannot stop cardiovascular disease or cancer or other NCDs. The estimates of future burden currently used seriously underestimate what is going to happen. And IDF is devoted to scientific excellence in diabetes for the best treatment, care, prevention, international cooperation, and policy development for the well-being of the people with diabetes. Continuous support to IDF is essential to maintain the global voice of the people of diabetes. No matter how much we criticize, that IDF is the only voice that we have that represents globally all the people with diabetes in the whole world. As you said, that as scientists, as doctors, you can go to any scientific excellence meetings, but nobody represents you other than IDF. Thank you for your attention.